So we'll just go ahead and get started with the history of PASRR and kind of where this all stemmed from. And if you can read your slide, there's quite a bit of information about the history of PASRR, where it started. It got initiated in about 1987, and it was really developed in process with the ADA, so the Disability Act. And so what they were trying to do is they were really looking to try and identify people that were in the Medicaid system or people that were in hospitals and clinics and things like that, and trying to find, you know, where they could, one, save some money, and where they could, two, get people back home to their communities and out of some residential facilities. So then if we keep going on, we're going to go to, it should be slide 4. And what we're going to do is we recently updated the PASRR manual. And along with that, we updated the mission and vision of PASRR in South Dakota to really identify what we're trying to do here and why our state is so great about doing it. We really want to ensure that anybody that's in a swing bed or nursing facility that has SMI or has DD are identified and evaluated and placed in the most appropriate, least restrictive setting. For those of you who can see the webinar live, I think it might be starting to pop up here. We're on slide 4, and it's talking about the mission and vision of PASRR. And so we want to make sure that people that are in nursing facilities are transitioned back to a community setting or a lower restrictive setting when they no longer need to be in the nursing facility. We also want to make sure that they're identified as needing specialized services or not needing specialized services. And in South Dakota, specialized services are only provided at the Human Services Center. And the reason that we only have it there is because according to CFR, so according to the federal regulations, specialized services include a very large team of doctors and physicians and other mental health professionals that have to provide treatment to each person. And so included in those are psychiatrists and psychologists, and we know that those are few and far between around our state. So we want to make sure that we don't require some of our other providers to have those individuals as part of their team and on their staff. So for us, specialized services is at the Human Services Center. So in terms of the difference in between a level 1 and level 2 PASRR, we identified during our regional trainings that people don't really know what the difference is. And so the reason that there is multiple levels or tiers of PASRR process is to kind of weed out the people that we really want to identify as needing this service. So in South Dakota, we don't have some of the problems that some of the larger states with the vast amount of people that come through the system. So with the level 1, what we use with the categoricals and the exemptions is to kind of identify those people that, yeah, they might have a mental illness or they might have an indicator of a mental illness, but realistically, they're probably not being placed into a nursing facility or into a swing bed because of their mental illness. A lot of times it's a short-term stay for like a broken bone or an injury. Sometimes it's a short-term stay for rehabilitative purposes, and sometimes they're just, you know, of a certain age where eventually, you know, your body starts to decline and you need those additional services. So the level 1 process is used to identify those people that are only going to need short-term services, or to identify those that, based on their age or some of their other criteria like dementia, may need nursing facility services without having to be reviewed for their mental health services. The level 2 process is really done to identify the people that do have a mental illness that are in our target age group, where they have a high likelihood of being able to return back to the community setting or to a lower restrictive setting. So the level 2 process is done and followed so that we can ensure that those people that do have mental illness or indicators of mental illness are in the least restrictive setting. So those are the differences in between the level 1 and the level 2. So as an example of the process, if somebody were to be leaving the hospital, let's say they have a broken hip, and they were in and they got surgery and they have a nice new titanium one, and they're going to go to the nursing facility for some rehab. Well, in the process of going through all of that, it's identified that they have a long-standing history of bipolar. So we want to make sure that that individual is not going into the nursing facility due to complications with bipolar or due to symptoms of bipolar, but because they actually need that rehab treatment. So the hospital or the nursing home would send the information to their local MRT to be reviewed for that level 1 categorical or level 1 exemption. And if the individual is over 65 with dementia or has dementia at all, or if they are going for a less than 100-day stay, those kinds of individuals would just be done right then at that level 1 process, and the person can transfer immediately. For people, so if somebody has bipolar and they're going because they have that broken hip, those individuals will be passed up to the level 2 in the peer office here, and we would review those to make sure that, yes, indeed, the individual needs to be in the nursing facility due to the cares required, and that they're not going in there just because of mental health symptoms. PASRR is really important to make sure that all these things are happening. They are part of our federal regulations, so all the things that we require are required of us through our federal partners. We want to make sure that our clients are being served in the least restrictive, most appropriate setting, and you'll hear that several times because that's a clear indicator of what the path we're going down is. We also want to identify their needs, so if they do have an identified mental illness, we want to make sure that they're getting the treatment that they want and that they need. Failing to complete the PASRR process can result in non-payment. That's a pretty important identifier that this needs to be done, and that is required through our federal partners and not through the state necessarily. So we want to make sure that we're following all those rules and regulations, and we want to make sure that individuals or that facilities don't lose their Medicaid certification. If it's found multiple times that you're not following the PASRR process or it's not being done completely or accurately, you could definitely lose that. Non-payment has been coming up a lot more frequently because we are now being required to review these a lot more in depth. All of this is listed in our new PASRR manual, and you can locate that on the DSS website. There's also a paragraph right below on slide 5 that describes some of the different issues that we have with the PASRR process being done inaccurately or not completely.
So the reason we wanted to do the trainings that we held regionally across the state back in August and offer an additional training because it's very important that everybody knows what our expectations are on the state level, as well as the federal guidelines that we have to follow as well. So many of the rules and regulations that we follow are also a part of the federal guidelines. So just keep that in mind that this is a federally mandated program, and that's kind of where we go off of our guidelines as well. So we wanted to make you guys aware of some recent changes that we made and that were put into effect on June 30th of this year after the legislative session. So back in 2012, we kind of started a collaborative effort between DSS and Department of Human Services to see what we could do to improve our PASRR process. We wanted to make it easier not only for the individuals being served, get them into the facilities faster and out of the hospitals faster, but also to kind of streamline our admissions and eliminate unnecessary reviews at the state level. So we updated a couple of our rules. ARSD, or Administrative Rules of South Dakota, there you can see we're on slide 6 here for anybody that can't view the presentation. So those rules were looked at, and we identified that there were some positive changes that we could make. So the first change we made was, as you all probably are well aware, previously we could get a physician order that stated the individual was intended to go for a rehab stay for less than 30 days in the nursing facility. We could obtain that physician order, send it in with the screening, and then do the level 1 PASRR. We've changed both the time frame, since we've identified that most individuals need a little bit longer time. Maybe they need 6 weeks of IV antibiotics, or they have some wound cares that will likely take longer than 30 days, or they just need 100 days or less to do some rehab and be able to get back home. So we changed the wording a little bit. We changed it from a rehab stay to a convalescent care stay. And what that means is it incorporates the IV antibiotics, the wound cares, basically any skilled nursing need, as well as a skilled therapy need. So somebody that is going into a facility that doesn't necessarily need skilled therapy can go under a convalescent care stay for wound vac treatment if that's their only need. Okay, so we have 100 days or less. We can get the physician's order for that, send it in with our PASRR screen, and then do the level 1 PASRR. We want to stress that we would like you guys to really try to do the less than 100-day stays if possible, if the physician is agreeable to writing that order over the hospital exemption. The 30-day hospital exemption has not changed, and we really want to encourage, again, that less than 100-day stay. So the other change that was made was related to our dementia guidelines. Previously, we had a rule that stated anybody that is over the age of 65 with a dementia diagnosis would be a level 1. We've actually taken that age limit off of our PASRR screen now, and I hope that you all have that PASRR screen in front of you that was sent out yesterday. We really want to make sure we're all using the updated forms. So both the hospital exemption and the PASRR screen, please make sure that you're using those updated forms that were sent out yesterday with the meeting invite. Share that with any hospital personnel, nursing facility personnel that maybe weren't able to attend. But we really want to make sure everybody knows that the new forms should be used with all PASRR screens. Going back to that less than 100-day stay, we want to make it very clear, too, that that physician order must come from an inpatient hospital stay. We can't get that order from somebody that's in the ER needing nursing home placement, or maybe at a physician's office or coming from home. They have to be an inpatient in a hospital to be able to utilize that less than 100-day stay. Another change we made on our screening form is we now want anybody with a dementia diagnosis to be sent in for a screen. And the reasoning for that is we just want to be aware of all of them to see if we can fit them into our level 1 process. Kind of the other part of our new dementia rule states that they can't have a severe mental illness that is higher on their diagnosis list than the dementia. So we really want to be screening all of those dementia residents and making sure it's an appropriate fit for the setting that they're going to be transferring to. Okay, we're going to move on to slide 8 now. We just want to make sure everybody is aware of where to find these updated manuals and forms so that if by chance you misplace the ones that were sent out, you always have access to them, and they're right on our website here. I'm going to try to take us there now. Hopefully we don't have any glitches here. So this is our links and resources page on our Adult Services and Aging website. If you scroll about halfway down under the nursing facility subtitle here, all of our PASRR information is found right under that provider bullet. Okay, so we have our new PASRR manual, we have our updated screening form, we have our some older documents from prior MDS 3.0 implementation, and we have our hospital exemption form as well. The hospital exemption form, again, the whole process of the hospital exemption didn't change, but we did update some verbiage on there. So again, we do want you to be using that updated current form. It also has the most current contact information for our MRT nurses across the state. One thing I do want to mention about Section S on the MDS related to PASRR, there's a question that indicates if I think it states if a level 2 has been done. And I just want everybody to understand that it always has to be a level 1 PASRR before it can become a level 2. So the answer to that question, if you have a resident with a level 2 PASRR, you would always indicate that yes, a level 1 PASRR has been done. All right, so we're going to switch back over to our presentation here. Bear with us a minute. again, please share those forms, share the website so everybody, we want to make sure everybody has access and is able to find those documents when they need them.
Okay, so now a little bit about follow-up information. So now that we know the difference between a level 1 and a level 2, with the level 2 PASRRs, we're allowed to make our decisions to do short-term, long-term, or specialized services. And what the short-term follow-up PASRRs are is typically when we do a level 2 PASRR, more likely than not, we'll do a shorter-term one and not a long-term one. We do intervals of monthly intervals, typically from 1 to 6 months. If the person's going to be there longer than 6 months, a lot of times they may be given a long-term PASRR just so that they have that ability to stay and get better. For the most part, though, we do 30, 60, 90, 120, and then the 180. And what we do is with these follow-up PASRRs, with these short-term ones, we do a courtesy call to the facilities about 2 weeks before the PASRR expires. So if you get one that has a short-term stay, it'll say on the letter that the individual is approved for how many days, so maybe 60 days, from a certain date, and that would be the date that it was reviewed. So about 2 weeks prior to that expiring, I typically call, and this is Michelle, and I will request to know if they are still there, if they're not there, and then some additional information about them. If they're not there, I need a discharge date. If they are still there and they're going to need a little bit longer time than what their PASRR allows, we request some additional information. And you can see that information right there on slide 9 about what we're looking for. And in addition to that, we really want to make sure that we're not getting an entire booklet of information. We usually can make our determination off of somewhere in between 25 to 40 pages. And we want to make sure that we only have the most current stuff. Getting an MDS that's 3 months old doesn't really tell us where the individual is at that time. So we want to make sure that we get the most recent updated information to really identify the type of progress they've made. So if they're making lots of progress, it looks like it's only going to need to be a little bit longer, or if they're really struggling to get better or they have some other setbacks, we want to make sure we give them that extra time for them to heal and get better, and then move back to their community settings. So we want to make sure that you are aware that these phone calls that you get are a courtesy call, and that the facility, the nursing facility or swing bed, is actually responsible for making sure that those PASRRs are not expiring. If you have any questions about those, or you're not sure of an exact date of expiration, or if it's going to be really close, say they expire today and they're scheduled to move on Friday, those kinds of situations we really want to be aware of, because we can adjust that here at our level at the state. In addition to that follow-up information, we want to make sure that we're aware of any changes that happen in the level 2 PASRRs that you have. So we want to make sure that those people are flagged so that when they do go home or to an assisted living, or if they pass away or if they get discharged back to the hospital, that we want to know. It helps us keep our records updated, and also keeps us from making unnecessary phone calls to you to make sure that they're there or not there and to follow up. So those types of things, you can just let your local MRTs know. For the most part, you have their email address, and it's pretty easy just to shoot them an email saying, hey, I have a level 2 that's going home today, or I have a level 2 PASRR that got discharged to another facility. If they move from a nursing home to nursing home, we need to know those updates as well so that we can make sure we're contacting the right place. In addition to those short-term follow-ups, for individuals who have a long-term PASRR, so there's not an expiration date printed on their letter and they're approved for that long-term care, we do biannual long-term cleanouts in February and August, and what that involves is we pull everybody that has a long-term PASRR, and we send out a letter to typically the social worker at each facility inquiring whether or not those individuals are still there. It's important to get those back in a timely manner because, again, that helps us keep up to date with our files and our databases, and it prevents us from having to call you again later or to follow up on them in case they do leave and go somewhere else. We want to make sure that we have all of our information accurate so that you can continue to get payment for those individuals and to help you out with any questions that you have. Okay, so when we were developing the training here, we wanted to make sure we kind of covered everything.
and really found out what the common errors are that are kind of holding up the PASRR process. When it gets to our level 1 MRT nurses, what are some things that we can ask your help on to improve the process and make it a smoother process and essentially get the individual discharged faster? So we want to make sure everybody's aware and just give a reminder. The nursing facility is ultimately responsible for ensuring that the PASRR screen is completed and completed accurately. Now, we're fortunate to have many of the hospitals in our state kind of take on this role as they're discharging patients to the nursing home. Most of the time, if not all the time, they will initiate that PASRR screen. We just want to ask that you make sure that PASRR screen is filled out completely and accurately, including, all the boxes, the date of birth, social security number, the diagnosis is important. Make sure you're signing it and dating it. If you do have a less than 100-day physician order, make sure the physician is signing and dating those orders as well. And then for the facilities, if there is a change in status and your resident maybe went to the nursing home without any PASRR indicators, we want to make sure that you're aware. Now, you should all be familiar with that the PASRR screen needs to be done initially upon admission. And if it's a level 2, you need to wait to hear back from us and from your MRT until you're able to admit that resident. Now, if you've admitted your residents and they didn't need a PASRR prior, we want to make sure that you're well aware as well that you need to keep that PASRR screen always on the chart. We encourage you to have a process in place at your facility to make sure those don't get thinned out of the files, as we do go back and look at those during our case mix reviews. So if there is a change in status, and when we say change in status, we're referring to a change in their mental health status, which may mean they have a new diagnosis of a mental illness, such as depression, bipolar, anxiety, whatever it may be, or they may have a new medication added that is a potential indicator of a mental illness, such as an Ativan. Maybe they get diagnosed, or maybe they get an order for Ambien for sleep. They might not have a mental illness along with that diagnosis or that order for the new medication, but we still need to be aware of those, and those need to be sent in for a level 1 PASRR review. So we want to make it clear that you have 14 days to report a change in the mental health status. Okay, so the day the order was received, you would have 14 days after that to fill out a new screen and report it to your local MRT. Again, this does not apply for your initial admissions. Okay, the initial admission ones have to be done. You have to hear back from us before you can admit your residents. If you're waiting to hear back from your MRT about a PASRR determination and it's taken longer than it perhaps usually does, sometimes our faxes, we get a lot of PASRR faxes every day. Maybe one got accidentally mixed in with another one, or it got for some reason it didn't go through on the fax. Make sure you follow up with us so we can get those done in a timely manner. I do want to stress too, there's 3 different types of PASRR follow-ups that may be required at your facility. The first one being that hospital exemption, which again is the 30-day exemption from the hospital to the facility. That is solely the responsibility of the nursing facility to follow up in a timely manner on those. If the facility does not contact us and that resident continues in your facility past the 30-day time frame, you're out of PASRR compliance, and that will result in PASRR non-compliance, which would indicate non-payment for a Medicaid resident. The second one's going to be that short-term PASRR that Michelle mentioned previously. Again, she does those courtesy calls, but it really is the ultimate responsibility of the facility to follow up. If a courtesy call gets missed, again, it's that facility's responsibility to make sure they're getting us the updated documentation. And then we also have that less than 100-day stay. We do track those at our level, but again, ultimately the responsibility of the facility. So if you don't have a good tracking system in place, I really encourage you to kind of start a process to make sure you're not missing any of those. All right, we're moving on to slide 12 now. Again, just some more common errors that we really want to stress it really saves us a lot of time of calling to make follow-up calls, getting more information. Again, just makes the process go easier ultimately for the patient to get into the facility faster. So we want to make sure that the person that's sending in the PASRR referral, please indicate to us which facility has been identified or you're thinking, is likely that resident may discharge to, as well as a contact for that facility and the contact for yourself on who to get back to. If you have any questions regarding the PASRR screen or the PASRR process, we really encourage you to give us a call ahead of time. If you're not quite sure on what you should do in a certain situation, we'd rather have you call us ahead of time and help you work out the question rather than having a non-compliance issue later on. All right, moving on to slide 13 now, we're going to talk a little bit about our out-of-state PASRRs. We do have a lot of facilities that we work with, especially on our border cities and hospitals. If you're sending somebody to an out-of-state facility, we just want to stress that each state has their own PASRR process, so we really shouldn't be expected to have to know what North Dakota's process is, for example. That should be their responsibility. The receiving facility should fill that out, so they would take on the PASRR process in that situation. Now, if you're admitting a person from an out-of-state hospital, let's say, we always want to make sure that the South Dakota PASRR is in place before admission. Unless they're coming from another nursing facility from out of state, we can admit somebody with an out-of-state PASRR, but would then expect the South Dakota PASRR process to be initiated as soon as possible. So with the new dementia rules and regulations that were recently put into place, some of you may be wondering about the current dementia residents you have in your facility that may not have a PASRR. We just want to make sure that those kind of come into compliance within the next year or so. So as you're doing their quarterly MDSs, talk with your MDS coordinator, try to catch all those dementia folks that maybe we don't have on our PASRR process yet. Just send those in as you identify them. Or you can certainly go back and kind of go through your charts this week and send those all in. We can get those taken care of for you. Again, there's not going to be any penalties, though, for the dementia individuals. Since this is a new rule, we want to get those all into compliance within the next year or so. Moving on to slide 14 now, we're going to talk a little bit about hospice. I just want to make it clear to everyone, just because somebody is going to a facility on hospice doesn't automatically mean that they need a PASRR right away. It's going to depend solely on whether or not they have that diagnosis or a medication order that would indicate a PASRR need. Okay, so typically people on hospice do have an Ativan PRN ordered. It really depends on your physicians in your area if they choose to write that order right away, or if typically they wait until later on in the process. So again, we just want to make sure case-by-case basis that we really don't need to initiate that PASRR process until the diagnosis or the medication has been ordered. If the life expectancy is less than 6 months, we do have a level 1 categorical determination, and typically hospice patients will fall into that level 1 categorical. Just wanted to talk a little bit and touch on our AdPay process. This can be a good resource if you're having difficulty placing some patients from the hospital into the nursing home setting. We do have about 7 different AdPay categories. You can find those back on our website that I took you to just a bit ago. Right underneath the PASRR information, you're going to see 7 bullets for our AdPay categories. So depending on the situation and the patient's needs, we may be able to offer some additional payment to Medicaid recipients pending their long-term care Medicaid approval. Okay, so if you have a patient that you're really having a difficult time placing, make sure and get in contact with me. We can kind of brainstorm some ideas to speed up the process of discharge. Our goal here at Department of Social Services is to make that process as quick as possible, just like those hospitals out there are trying to discharge. But we want to make sure it's an appropriate discharge and appropriate setting that that individual will be transferring to. If you know you have somebody that is admitted just recently, they need some time in the hospital, but they will need a nursing facility upon discharge, and you anticipate that it will be a difficult placement, go ahead and give me a call as soon as you're aware of the situation, and we can start working on discharge plans immediately. I just want to remind everybody, discharge planning is the ultimate responsibility of the discharging facility. So DSS is happy to, again, kind of brainstorm some ideas, see what we can do to help in that process, get some resources in place. But again, it is the ultimate discharge of that discharging, or ultimate responsibility of the discharging facility. And with that, I do want to talk briefly about our new program within Department of Social Services called Money Follows the Person. Hopefully most of you are aware of that program by now. Money Follows the Person is a really great resource for anybody who's been in a facility or intermediate care facility for 90 days. They do have to meet the criteria for one of the 4 waiver programs within Department of Social Services or Department of Human Services. So in conjunction with the waiver program, Money Follows the Person will offer some additional supports financially, help explore resource options, explore housing options, that sort of thing, for 1 year post-discharge into the community. So it's a really great option. If you have somebody that may meet this criteria, or you think is really trying to get back out into the community but they have some barriers, I would encourage you to either contact myself and I can make the referral for you, or I can point you in the right direction for that program.
In addition to some of the discharge planning that we're talking about, as an accepting facility, so as a nursing facility or swing bed, as you're going through some of those referrals, we know that there's been some complications with some difficult placements in terms of criminally charged people or people that have criminal history, including those that are sex offenders. I would really encourage you to really review those very, very carefully. We do have a lot of individuals that are coming out of the penitentiaries and out of jails at an older age that are going to need those services that you guys can provide at those facilities. So in terms of identifying whether or not you can meet their needs or whether or not there's any kind of risk to your other residents, we want to make sure that you're reviewing them, because we don't want those individuals in an inappropriate placement either. There are a lot of options to find additional information about those types of individuals, including contacting the state penitentiary that they're residing, or looking at their criminal history or their records to find out what kind of individual they've been at the penitentiaries or in the jails. So the Division of Behavioral Health here with DSS is sister partner as the Correctional Behavioral Health staff, and we want to make sure that the communication is open between everybody, because those individuals are going to need services as well. So we really encourage all nursing facilities to really review those people and not just say no immediately. We want to make sure that there's no risk, and if there are options to assist with some of that stuff as well, including possibly doing an ad pay or something like that to get an individual room versus a shared room, or some other different options as well, possibly counseling, or for those individuals that have a substance abuse history or substance use history, we have the availability to maybe get them into treatment or have treatment come to you guys, and that way you can admit those people and give them the services, the skilled nursing services that they need, along with getting them either their mental health or their substance abuse treatment.
I'll just touch a little bit on, I'll go a little more in depth on our ad pay categories. If you're not familiar with that program, I really do encourage you to become familiar with it and utilize it when it would be necessary. So our first category that we have is our challenging behavior individuals, and we have 2 facilities right now that we're partnering with, Sunset Manor down in Irene and Canastota Good Samaritan Society. So we have the capacity to serve about 26 people right now with challenging behaviors. Many of them may be coming out of HSC to return to the community, or we certainly want to have the option to prevent people from having to go to HSC if we are aware of a potential referral that is headed in that direction, not appropriate at the facility they currently are at, but would do well in a smaller setting, more focused on the needs of the challenging behavior individuals. We're also working with a couple other potential facilities to create more capacity for that category as well. We also have a ventilator unit at Avera Prince of Peace in Sioux Falls that has the capacity to serve 4 individuals who require ventilator support. Additionally, in Sunset Manor and Irene, we have a TBI, or traumatic brain injury unit, which serves 8 individuals that have had traumatic brain injury. They have a very diverse program where they do lots of therapy, and they send the individuals to work if they're able to do that on a Monday through Friday basis, and it's really a diverse program with lots of benefits for those folks. We also have ad pay potential for those with wound care needs, such as a wound vac. Maybe somebody has severe wound needs and needs a specialty mattress. We can also help pay for some of those specialty type mattresses. And then we have a category for multiple complex medical conditions, and that can encompass really a lot of different things. Maybe somebody needs some additional bariatric equipment in their facility to be able to serve somebody. We want to be aware of those and help that facility be able to serve those individuals rather than having to send them across the state. So really our mission here with DSS is helping individuals succeed and remain as close to their support systems as possible. So we want to help out those facilities and make that possible for them. So as part of our multiple complex category within our ad pay, we have a fairly new service available for those individuals in a nursing facility. I should state too that to qualify for our ad pay program, again, you have to qualify for the long-term care Medicaid as well as the nursing facility level of care. So we're only able to provide this in the nursing facility setting, so not the swing bed or assisted livings, but just the nursing homes. And then each category has its own list of criteria that you can find on our website there. So again, back to the palliative care services, maybe an individual in your facility would really benefit from palliative care services, but for whatever reason, maybe they're not qualified for actual or formal hospice care, or they choose not to elect hospice services. If you've identified an individual that would benefit from palliative care services, we can potentially provide some reimbursement for those services and for basically the home health care team or the hospice team to come into your facility and meet those needs that individual would certainly benefit from. So if you have questions on that, if you have a potential candidate in your facility, feel free to again reach out to me and we can talk through that individual's case or need.
So some future things that might be coming up that we want you to be aware of involve a couple of different things, both federally and just statewide. The reporting currently in Section S, which is a state-chosen section of the MDS, there's a place where it asks whether or not the individual has a mental illness. There is a potential possibility that in the near future we're not only going to be asking whether or not the person has been identified as having a mental illness, but also require reporting of any kind of treatment that they receive. We're not entirely sure quite yet what that's going to entail, whether or not it'll be a detailed description of the services or if it'll be a more broad, general possible drop-down box that includes medication management, refusing services, or individual and group counseling, or just some other types of therapeutic treatment that they might receive. So we want you to be aware that that could be coming, and if you have any votes on the issue, we'd sure like to hear your opinions on it. Also, recently there was a PTAC, which is the PASRR Technical Assistance Center, which is our federal partner. They had a conference in March and kind of discussed some of their future plans and where they'd like to see the country go in general in terms of PASRR. And they are planning to do an on-site visit for each state in in the upcoming year. That we have not been notified of when that will be. So it could be a couple months from now, it could be towards the end of next year. We will be sure to send out an email and let people know. We are asking that a couple of facilities volunteer for this visit. We know for sure that they'll be interviewing Beth and I. They'll also be interviewing our MRTs, but they will want to see some of our different levels of care. So they'll definitely be going down to the Human Services Center, but we'd like them to be able to see at least a couple of our nursing facilities. So if you think your team does just an awesome job at the PASRR process, we'd really like to hear that, because we want you to get a pat on the back as well for our state's plan with PASRR. So in addition to that, we really want to make sure that the communication lines are open in between Beth and I, the MRTs, and our nursing facility contacts. There's going to be some more changes coming up, but we want to make sure that everybody's using the correct forms, that everybody has the most up-to-date information, and that in terms of having an on-site visit, that you know that we're coming. We really don't want to surprise anybody and just show up on the doorstep when you're unaware that we're coming. So we want to make sure that you're checking those emails. We know that you get flooded with emails, as everybody does, but they are very, very important, and a lot of times if you're not using some of the updated information, it could cause issues and some extra complications like having to redo a form. We were informed during our regional trainings that we went around to that people didn't know about it because they didn't bother to open the email. We really don't want to hear that anymore. As a professional, it's your responsibility to be using the most updated and current information that we provide. So we're going to go ahead and go into the HSC geriatric program and the clinical review process through HSC. During our regional trainings, we had Stephanie Auk and Jeremy Johnson come with for a few of those to discuss it. Since they're unable to attend, I'm going to go ahead and go over it for them. The clinical review process is a great process that was identified or developed during the 2011 Behavioral Health Work Group Plan. And the geriatric population, so the PASRR, the people PASRR serves, was identified as one of the groups of people that are really underserved in our state. And so they wanted to identify different ways that we could help that population to streamline facilities and to prevent inappropriate admissions to the psychiatric hospital. So they identified this process. It took them quite a while to really work out the kinks, but they identified the clinical review process to really keep people in the nursing facility and at assisted living instead of having them transported across the state. What they want to do is they want to be able to provide assisted living facilities and nursing facilities with resources and interventions that really help the resident to stay there. They really want to support the nursing facilities to really be their own advocates to keep people in those facilities. So the clinical review team, to request a clinical review from the HSC staff, what will happen is this is only good for people that are currently in swing beds, nursing facilities, or assisted living. So if they're at home, this process wouldn't be able to be utilized. But any of the other facilities are sure welcome to give them a call. So the main numbers are on slide 20, and they have the fax number also listed so that all the documentation that they request can be submitted to them as well. And they want to make sure that you guys know that it will take 24 to 48 hours. So if you're having an emergency and an individual needs to be taken into custody or taken to the Human Services Center due to that emergency, that this process won't be beneficial because it will take 1 to 2 days to complete. But they will return your request within that time. So they want to make sure that you're aware that you want to really get on top of these situations when people start having behaviors or their personality starts to change, or if you notice that they're starting to have some other complications in terms of their mental health. So the types of information that they really want you to gather include a recent history and physical, any psychiatric records. So if they are an individual that has gone to the Human Services Center or Vera Behavioral or Rapid City Regional West, any of those places multiple times, they really want to know that psychiatric history. They'd also like to know their MAR and any medications, any recent labs, and some of those other notes that you guys take and would typically send for any type of review. They want all that information faxed in, and again, that number is listed again. So then, once the information is received, they use it with a clinical team, and that includes a lot of different individuals there, including the psychiatrist, the MD, nursing staff, social work staff, PT, STOT. They have a nutritionist on staff, and a couple of other people that they involve into the team that can really help out in reviewing those medical records and helping identify some of the potential issues that they may be having. Again, the whole purpose of this process is to really reduce those number of involuntary commitments to the Human Services Center. The geriatric population is, of course, a vulnerable population already, and so we want to make sure we're taking good care of them. One situation that we were aware of during our regional trainings was when an elderly woman who was in her middle 70s she started acting a little strange and started becoming a little aggressive and was getting upset, and the nursing facility team did an involuntary commitment on her because they thought they could no longer handle her outbursts. And she was transported 6 hours to the Human Services Center, where it was identified that she had a UTI, which was causing all of these behaviors that she was having. And so within 24 hours, she was then driven back to the nursing facility. So she spent 12 hours in a car being transported because she had the UTI that nobody bothered to check her for. So we really want to prevent those things from happening, because that, of course, is a trauma in itself to these individuals. And we want to make sure that we're providing them good services and preventing any of those unnecessary transports. Okay, we're on to slide 23 for those of you who are following along via the paper version, not online. Again, we want to make sure that you're aware that it's 24 to 48 hours, and that does not include weekends and holidays. So if you submit some information on Friday afternoon, it could be Monday or Tuesday before you receive any kind of suggestions from them. If there is a crisis that you guys can't handle, we want to go ahead and do that involuntary commitment, or at least identify possible other reasons for the crisis happening, or to utilize your local community resources for those. The first picture that you notice is from 1879. It's 135 years old. It's what the Human Services Center started out looking, down in Yankton, where they thought that the state capitol would be. Currently, the Human Services Center is approximately 10 years older than the state of South Dakota. And back in that time, again, the psychiatric center was for individuals that had any kind of indication of mental health, or a lot of times developmental disabilities, or they were just difficult people that parents couldn't take care of, or families just kind of what we call dumped. And we want to make sure that that doesn't happen anymore. But back then, these individuals were not transitioned home. They were usually there long term. So even when their psychiatric conditions were stabilized, they would still stay there. And a lot of times they would just help out. They would almost become one of the staff. The Human Services Center back there was a fully functioning farm, and they had animals, eggs. They made their own milk and butter. They grew their own vegetables, and because that's what people were able to do once they were stabilized, but they had nowhere else to go. So they ended up helping out and becoming one of the staff, more or less. The second photo is what HSC currently looks like. In the bottom left corner, you'll see the circle. That is the admissions building. That is where people start out at. And then as you go around, those are all the different units. And then in the back corner, you can see where some of the older buildings from the original Human Services Center were. For those people that go down to Yankton often or kind of know their way around, just opposite of the street of the building with red top, if you have it in color, is where Walmart's currently at. It's a good reference to have so you can know where to find it if you forever need to go there for any reason. Currently, HSC has a 295 bed capacity. They do state-of-the-art treatment, so when a new treatment comes out, they're one of the first hopping on board trying to get involved with that. And they do provide both mental illness and chemical dependency treatment. They are part of the Western Psychiatric State Hospital Association along with SADAHO. They do a lot of different programmings there, and they're one of their great abilities is to treat co-occurring disorders. Some of the different programs that HSC provides includes adult acute psychiatric treatment, rehab and recovery, intensive treatment. They provide a specialized program for adolescents, for chemical dependency, and then also the geriatric program that we utilize with the PASRR process. They are a licensed nursing facility, and currently they have, I believe, just over 60 residents, so they're not quite at full capacity, but they are close. And they usually stay right around that 60 mark, so that they have room for emergency admissions. They do use a multidisciplinary team, so they use physical therapy and occupational therapy along with rec therapy and some other additional therapies. They have a family practitioner, and that is Dr. Neubauer, and they have a consultant psychiatry and psychology, and right now they're using Dr. Amiet. The next photo is of what Willow 1 looks like, and Willow 1 is part of the geriatric program. So this is where individuals who are elderly will go for their geriatric stay. There are 3 units that are geriatric specific. Spruce 1 and Spruce 2 are both long-term units, so those are for individuals that are going to be there potentially for the rest of their life, or for a long-term stay where it's going to take quite a while for them to rehabilitate. Willow 1 is for shorter-term stays, so for individuals that need possibly a medication adjustment or some short-term therapy, intense therapies, and then they typically transition back out to the nursing facilities. We want to make sure that our nursing facilities are aware that we do expect you to take residents back if they leave from your facility. We understand that sometimes they can be difficult, or you may have complications with them. But if you're in their hometown where they grew up, where all their family is, you're their home. And we want to make sure that if they've been with you for a long time, that they can come back to where they're familiar. We really don't want them bouncing all around the state if we don't need to have them doing that. And we want to make sure that they can go back to a familiar face. So as we go on through the slides, the short-term residents do receive biweekly visits from the psychiatrist, and that's to make sure that those individuals are getting those changes made that they need and those medication adjustments. Slide number 31 is the process of how the geriatric program has admissions. And of course, it starts out with a call from a nursing facility. We really encourage you to do the clinical review before doing an involuntary commitment. If you do this clinical review, they will review that and get back to you in 2 days. From the individuals that we've talked to during our regional trainings, this process has gone really, really well. And what we do with the clinical review is they provide suggestions to try, whether it be some different labs or something as simple as maybe finding a different roommate, putting them next to a window, possibly changing a schedule, identifying whether or not there was any recent changes in medications, and things like that, and provide some both medical and non-medical ideas and suggestions for change. If you do not accept the clinical review, which we highly recommend, you can do the emergency IVC, which can be the 5-day hold, and if that's permitted, it could go to a 30 or 90-day commitment. Once they are committed, they go into HSC. They get their medical clearance because, of course, HSC is a psychiatric hospital, not a medical hospital. They are limited to what they can provide medically. If they are not medically cleared, they will have to go to a regular hospital. So that can involve out-of-state and state hospitals. A lot of times it's a Farrar, Sanford, or Rapid City. And we want to make sure that those individuals are medically cleared. And then they will, if they already have a PASRR, they can be admitted into the geriatric unit, and that would be considered a change in their mental health status. So then HSC would have 14 days to let us know, so we could do that change. If they do not have a current PASRR, or if they're going to HSC from somewhere other than a nursing facility, so if they're in assisted living, they wouldn't have a PASRR, that they will get admitted to the acute side of HSC. And in the acute units, there's all kinds of different kinds of clients. You have everything from 18-year-old boys to 90-year-old women, and so we want to make sure that our geriatric population stay very short time in those acute units. We want to get them onto the geriatric unit where they can get those services and have the staff ratio that really benefit them. If there's room in the geriatric program, they'll get transferred down into the geriatric program, either immediately if they already have a PASRR or after a short stay at the acute unit. From there, they go through their treatment, and eventually they get out back into the nursing facility or assisted living where they were originated from. Okay, on slide 32, hopefully everybody's able to follow along so far. The goals of HSC are really to identify, get them in, treat them, and then return them back home. Again, we want to make sure that these individuals are returning close to their communities, back to their families, or back to where they're used to be. We don't want them 6 hours from their support system. We want to make sure that they can get as close as possible to the people that have already been working with them and already know them. The objectives of the short-term stays are, again, to make sure that these admissions are appropriate, to use the clinical review before doing the voluntary commitment, making sure that any medical interventions such as lab work, identifying recent med changes, identifying possible toxicity from either a medication or something else, and to make sure that the supports are there. Once the treatment is complete, we do want them going back. Again, we want to really pound that in, that we want these people going back to the nursing facility where they came from, or at least close to their family. The very last slide is our contact information. We want you to utilize the sheet that was sent out with the presentation with all of the updated phone numbers and fax numbers. Down at the bottom, you'll have Beth and mine. If you have the PASRR manual, that will also include the DD contact. And we want to make sure that you print out that sheet of paper with all of our contacts, so you have it available to you and to anybody else that might be covering for you, so that they know who to contact in the event that we call for a follow-up, or if we have additional questions, or if they have questions about somebody admitting that needs a PASRR. So we want to make sure that you know who your regional MRT is and how to get a hold of them as well. If for some reason you're unable to get a hold of your regional MRT and you're not sure who is on call, we want you to go ahead and give Beth or I a call, so Beth or Michelle a call if you can't get a hold of that MRT, and we'll be sure to help you out with any of those questions you have. At this time, we're going to try and open it up for any questions that you might have. And so we're going to be unmuting you, so if you have a question, we're going to have you chime in. If there's more than one at a time, hopefully we can kind of get these going in line. All right, you've now been unmuted, so if you have any questions, please let us know.
And a reminder, if you've muted your own line, it's going to be #6 to unmute your line.
Here. Oh, love it.
Moaning. Yep. She was up here talking to Buddy, because I know she's having him do some papers and stuff. She was up here talking to him.
We're hearing some background noise there, so if you don't have a question, if you could mute your line by pushing *6.
Did you do it?
All right, if there's no questions, we surely encourage you to give us a call or send us an email if it comes up where you need some assistance. We are available through typical state hours, so Monday through Friday, 8 to 5. Beth and I are both on Central Time. Feel free to give us a call or send us an email.
Oh.
Just a couple things I want to follow up with. Again, we're stressing the utilization of that less than 100-day physician order to get that level 1 determined.